Hello.
Yeah.
Yeah. Good evening, all of you. On the behalf of MyIP, Dr. Vikas More, welcome all of you. And first of all, Eid Mubarak to everyone. On this auspicious day, we're having a very unique CME that's Pictorial Pediatrics, a brainchild of our dear Bhavesh sir, and very well supported by our dear President Dr. Ram Gopal sir and his able secretary, dear Dr. Amol Pawan. Today we are having a very well-known pediatric endocrinologist from Nasik and Khandesh area, Dr. Tushar Godbole, who is working as a director of Harmony Health Hub, Nasik, also visiting at Aurangabad and Dhule. He is also assistant professor at Vasantara Pawar Medical College, and he has various national and international publications in this field. He also got a Best Research Paper Award at IIT Delhi 2010. And so this concept is that like we are having, he will be presenting various pictures, and through which he is going to teach us how to identify the diseases and how the thought process will like it will stimulate our thought process to manage the child. And now we are also having a respected moderator, Dr. Satish Sane sir, president of Navi Mumbai. He is a director of Sanvi Childcare at Agar, and his special interests are in pediatric critical care and pediatric infectious diseases. So all well learning to all of you, and many respected doctors have joined. I am not mentioning because of the shortage of time. Over to you, Dr. Satish Sane.
Thank you. Yeah, thank you, Vikas, for your kind introduction. I think today's webinar will be a hit because the topic chosen by Dr. Bhavesh sir and Ram Gopal sir and Amol sir is like fantastic. What we call as we need to have the knowledge about our images in endocrinology, because the diagnosis is in front of you, but we are not able to make it out. And to solve this query, I think we have the perfect man from our Maharashtra, that is Tushar Godbole. But before that, I would like to say that on this platform right now, there are many stalwarts which are like teachers of teachers. First of all, I would like to welcome Dr. Srinivasan sir from Pondicherry. He is from Jeepmer. He was the director of the Jeepmer. So I would like to just ask sir to say two few words. Dr. Srinivasan sir.
Yeah, it's a wonderful this thing. I attended the previous ones, and it's a wonderful this experience. So I'm happy that such a thing is continuing. I'm able to see from Westport, Connecticut, USA. You have made it possible for learning. Thank you so much. So I am sure, of course, there is going to be a great feast in endocrinology, because I've heard about him and I've heard also once or twice earlier. Thank you so much.
So I'd like to ask our MyIP President, Dr. Ram Gopal sir, to say a few words.
Good evening, friends. Welcome. I can see Nitin Shah sir also. So respected sir, past CIP President, and respected our today's faculty, Dr. Tushar Godbole, and today's moderator, Dr. Satish Sane. You know, the visual impression is the best impression. So our concept is based on that. By visualizing, how can we diagnose? And when we are learning, once we see the pictures, I think we can remember the things for a longer time. So welcome all. I will not take much time, already 9:06. So over to Satish. Before that, I'll just say Amol to say a few words, and then we can directly start the program.
Thank you, Ram Gopal sir. Already 230 people, almost 230 people have joined. I, from the team Maharashtra IP, I again welcome Dr. Nitin Shah sir, Dr. Yash Srinivasan sir, Dr. Tushar Maniyar sir, Dr. Manjusha Sherkar ma'am, Women Committee Chairperson, Grivita Raikar ma'am, Co-Chairperson, and many stalwart pediatricians who have specifically joined for this Pictorial Pediatrics program and to enrich some academics in us, to enforce us with some pictorial presentation and the diagnosis. We have Dr. Tushar Godbole with us. So I again welcome today's star faculty, Dr. Tushar Godbole from my hometown, Nasik. So I hand over to Dr. Satish Shane sir. And before that, I just request Dr. Nitin Shah sir, President of Presidents, to say a few words about this program and guide us. Please, sir.
Yeah, please, sir.
साहेब सगळे रथी महारथी जमा झालेले आणि एकदम महामहारथी आता बोलणार आहे तो बोलतो सुद्धा चांगला गातो सुद्धा. Let us hear him and have the pictorial quiz in a very musical way. So over to the faculty whom everyone is waiting for.
Yeah, please, please. Tushar sir, please, you can start.
Thank you, sir.
So Tushar doesn't require an introduction, but he's not only from Nasik, he's from Maharashtra. We also see him as our many of our patients also with him, even from Mumbai, all rest of Maharashtra. So please, Tushar sir, you can start your book.
Thank you. Thank you so much. Indeed, a pleasure and honor to be here in front of all of you. And I'm feeling a little bit of pressure because so many of the stalwarts are attending this session. Yesterday, I was, having a casual chat with Dr. Grivita that so many programs are happening and will people really come and attend? And it's, actually very much pleasant surprise that almost 230 people are there and attending this academic feast. So without, any further ado, let me go and straight away share my screen. So in next 30 to 40 minutes, we'll be going through a few pictures. They are kind of spotters where you would, make a visual impression. I'll be providing with a very brief clinical history because this is all about pictures and making a spot diagnosis based on pictures. I hope my slides are.
Yes, sir.
And in full.
Your screen is visible.
Perfect. Yeah, so I thought yesterday we spoke with Dr. Satish and we thought that we should begin with some common cases and build our story towards some rare entities, and at the end of it, everyone should get benefited with some take-home message. So this is the first spotter. I think most of you have seen this already.
Sir, we are just getting the message. You have
screen is not visible
screen is
yet.
not visible.
Okay,
Screen not visible, yes. Full dark.
You can stop share and restart also, no problem.
No, screen is not visible. We are
Pallavi madam is having it handy with her.
No, she's not.
No, sir. No, ma'am.
I will just give her a call.
Yes, wait. Tushar will manage everything.
Is it visible now?
Pallavi ma'am.
Yes, sir.
You
Tushar,
are.
sir? Yes,
Now
it
we
is
yes,
visible.
now
It is
now
visible.
it's
Yes, sir.
yes.
Thank you.
Yeah. Okay, so this is the first slide. First case, she is a 13-year-old female came to your OPD for some cough cold fever, and you being an astute pediatrician quickly took her height, weight, and plotted her on the IAP 2015 growth chart and found out that she is short but normal for her weight. She is prepubertal. In Tanner coding, she is B1, P1A1M0. So that is no breast development, no pubic hair, no axillary hair, and menses are yet not achieved. There are multiple facial nevi, and on inquiry, she is poor in mathematics. So I believe most of you have identified this spotter because she is standing in front of you in this peculiar posture of, her hands in, full supination, and you can make out the carrying angle. But in reality, patients don't stand in front of you like this and there are subtle clues that you are supposed to pick while you're examining this case for common ailments such as cough and cold. So what are the common features that one must be looking for are the epicanthic folds that you can make out in the first picture, slanting eyes, there is low set ears. On your left side image, you can see the webbing of the neck, which is present due to the problems in the lymphatic development in utero. And these neck folds may not be appreciable in each and every case, but the typical facial features you can appreciate. Please, on your right side of the screen, look at the multiple nevi, which is a very, very peculiar feature of Turner syndrome girls. So any girl that comes to you with short stature, subnormal mental development, especially in the area of mathematics, she has such facial features such as nevi, one must think of the diagnosis as Turner's syndrome. It is common cause of short stature in girls. If you see 100 girls that come to you with short stature, it is often said that almost 5% of them will have Turner syndrome. Typical features: short neck, multiple nevi, misshapen ears, increased carrying angles, and delayed puberty. The key points to remember is one should be diagnosing the Turner syndrome right in the pediatric age group, so that these girls are typically benefited with the growth hormone therapy followed by your sequential estrogen replacement. Sadly, even today, after so much of sensitization about Turner syndrome, so much of sensitization about growth charts, these girls are often missed during their pediatric age group, and they are often picked up late by the gynecologist, where they see these girls for primary amenorrhea. So it's indeed an appeal to all of the pediatric colleagues who are listening to this talk that any girl that comes to you with short stature, please remember these features, and every child deserves to be plotted on a growth chart to be picked up right in time to get diagnosed and get treated. Now this spotter, this child has been referred for gynecomastia, but what is so peculiar about this is the unilateral gynecomastia. But the story is not that simple. The patient has been seen by a surgeon, and the surgeon has planned for an FNAC thinking that this is a breast tumor, and before this planned procedure, some procedure has been planned, the child has been sent to Department of Pediatrics in a medical college for fitness. And here I see this patient and I make a diagnosis of gynecomastia. So unilateral breast swelling, is it very rare? All of you are already knowing that gynecomastia is a common condition in pediatric age group between 12 to 16, where almost 30 to 40% of the boys would be coming to you with little bit of breast enlargement, which is tender to begin with, later on resolves within a matter of 3 to 6 months. But the peculiar part about this particular case is it is unilateral. Please remember, friends, that even in girls, the normal thearchy, the normal breast development can also begin from one side, and it may be a matter of 6 to 12 months before the other side, starts showing up. So unilaterality of the gynecomastia should not be, a matter of great concern. Gynecomastia as well as thearchy could be unilateral. It is often tender to touch. Sorry.
Just in between, we can ask the questions for the
Yes,
clarity
please,
of this one.
Yes, sir. Yes, sir.
So the child, like same child of 3 years comes, then in the unilateral with the same presentation. So what we should think of?
Correct. So I believe you are asking for a 3-year-old female.
Yes, yes.
Yeah. So then it becomes a totally different story again. Children between 1 to 3 years often come to us. Girls between 1 to 3 years often come to us with breast development, which is often, it turns out to be the benign thelarchy or isolated thelarchy variant. Even then, unilaterality is common. So unilaterality does not, necessarily mean that it is tumor. A simple palpation of the breast tissue you could get the concentric, appearance. It starts from the nipple areolar complex and then extends into the periphery. You have to probably palpate at least 100 pubertal girls to know what is the normal feel of the breast, which is often tender to touch. Surgeon had advised FNAC biopsy in this particular case of 12-year-old male. And here is the diagnosis of pubertal gynecomastia. So in order to make a diagnosis of pubertal gynecomastia, the child has to be a male between 12 to 16 years in the early part of puberty. So imperatively, I need to check his gonads and confirm that the child has entered puberty. The testes are typically between 8 to 10 ml in size, and this is the common presentation of pubertal gynecomastia. Generally, no treatment required except wait and watch. Dig into the history of any drug intake like digoxin, and just wait and watch is the general dictum here. Very, very common in adolescents. Don't be fooled by the unilaterality. Now, this is another spotter where Dr. Satish had just asked that what if this is a small girl, maybe a couple of years, 2 years or 3-year-old, comes to us with the breast development. So we have been
commonly see actually, yeah.
Right, sir. So the isolated thearchy is very common. Typically, you see these girls at around first birthday, and the mother will not remember because the onset is so insidious that the mother will not be able to pinpoint that it started at this age and now progressing. The mother would say, it's probably it was there. We have not noticed, but they will come to you at 1 or 2 or 3 years of age, and it is often non-progressive. The girls are otherwise developing well. And we have been told that you check the height, weight, plot it on a growth chart, confirm that the growth is normal, do a basic ultrasound, and maybe just wait and watch is the general dictum for the isolated thearchy variant, which is very common and self-limiting. Now, what is different in this particular girl that you see on your screens? She's a 2-year-old female, has come to you with breast development since last 2 months. No pubic hair, no axillary hair. And as somebody had correctly, listened to some talk in some conference, and the advice of wait and watch was given to this girl. Now, see what happens. There is a large cafe au lait spot sitting on her face, which is actually giving you the clue towards diagnosis. And lo and behold, within next couple of months, this girl actually developed one pervaginal bleed. So now you have a small girl, 2-year-old baby, breast development since last 2 months and one PV bleed with that large cafe au lait spot sitting. What is the diagnosis here? So this seems to be the peripheral precocious puberty because these steps, the sequence of puberty is altered. So you have thearchy followed by menarche with skipping of milestones, and look at the aggressive nature. 2 years is not the age for anybody. Even with the central precocious puberty, it is very, very unlikely that a girl will get menses within that short span of 2 months. So this has to be peripheral precocious puberty. And with that large kind of cafe au lait spot sitting on the face, the diagnosis is peripheral precocious puberty with McCune-Albright syndrome. So this is another case with the same syndrome, McCune-Albright, where you get a large cafe au lait spot. Look on the right side of the body, you can see a large cafe au lait spot, and on the left side, you are getting the leg deformity with recurrent fractures. Look at the X-ray, you get the lytic lesions in the mid shaft, which is giving rise to multiple fractures, and the deformity giving rise to that shortening of the left leg. This is the fibrous dysplasia, a part of your McCune-Albright syndrome. So points to remember: cafe au lait spots with precocious puberty, cafe au lait spots with fractures, cafe au lait spots with any isosexual or heterosexual puberty. Please remember McCune-Albright syndrome as the cause. So McCune-Albright syndrome, where you get the peripheral precocious puberty, the LH-FSH will be low, the estradiol will be very high, and you get cafe au lait spots. It's an activating mutation of the hormone receptors. So you have the LH-FSH that is not acting, but the receptors of the LH-FSH present on the ovaries are actually hyper functioning, And as a result, the girl will have an ovarian cyst, which is secreting the estrogen and giving rise to the puberty. The common associations are hyperparathyroidism, hyperthyroidism, GH hypersecretion. So they may have, tall stature and fibrous dysplasia. Now, this is a common condition. All of you see at least, one case in a couple of months, but this is not how the child comes to you with in that, prominent calf muscle. This is 10-year-old male child, 115 centimeters with 30 kilos of weight. So in short, the child is short and obese, prominent calf muscles. So you dig into the history that does the child play football? No, sir, not at all. The child is barely able to walk. The child is very, very lethargic, sitting at his own house and not even attending school because there is proximal muscle weakness. So there is proximal muscle weakness with pendular knee jerk. I think I have made the diagnosis very, very clear now. Are there any guesses in the chat box? Yes, this is hypothyroidism, but not simple hypothyroidism. This is a long-standing untreated hypothyroidism giving rise to Cocker-Debré-Semelin syndrome, which is a rare entity, but you can see them in, at least once in your OPD. If you get to see long-standing untreated hypothyroids, just roll their, pant sleeves, and you can see those such kind of, bulky muscles. But these are the pseudo hypertrophy kind of thing, the similar to what you see in the Duchenne's muscular dystrophy. So this is Cocker-Debré-Semelin syndrome, prominent calf muscles along with other signs of chronic hypothyroidism. They often have CPK elevation in hundreds, not in thousands. So in your DMD, your Becker's, your Duchenne's, you will see the CPK elevation that is in thousands, whereas here you can see CPK elevation that is in hundreds. Now this is the clinical feature of a frank hypothyroid. The same girl, the leg photograph, this is the same girl in a standing position in front of you now. Now you can make out all the clinical features where she has a sallow complexion, blank, dull-looking face, and depressed nasal bridge, apparent hypertelorism. You are getting that swollen, face with swollen lips, upturned lips, with periorbital puffiness, dull, blank-looking face. She is severely short stature. She also has dry hair, dry lusterless hair, and dry skin with constipation. She also has apathy and hoarse voice along with constipation. It is very important to know that constipation is very common in hypothyroids, but hypothyroidism is not common in constipation. So don't just blankly send, TSH for all children that you see with constipation. Also look for the other signs and symptoms of hypothyroidism when you are, taking care of the pediatric constipation. I think any child who is constipated but normal height, one should not send thyroid profile, because hypothyroidism giving rise to constipation is actually a late symptom. By then your height is already compromised. So a short child with constipation, one must think of hypothyroidism. And here you will not be sending plain simple TSH. You will also be sending free T4 or total T4 with TSH. Now a bonus spotter to all of you. 13-year-old female, short stature with dry skin, irregular menses, palpable abdominal masses. So these are the masses that are actually palpable on your examination, your per abdomen examination. So what are these? Are these palpable kidneys? Are these fecolates? What are these? What are these tumors that are not just palpable but visible from outside? Now the ultrasound shows large ovarian cysts, and these are the big cysts that are seen in the ovaries. They are fluid filled with thin septations. What is going on? Is this ovarian cancer? Is this ovarian tumor? What is the diagnosis? Look at the clues: short stature, dry skin, irregular cycles in a 13-year-old female. Can this be Turner syndrome? Short stature? No. Turner syndrome, by 13 years, the ovaries will be shrunken. They are streak ovaries. Here we have ovaries that are very, very bulky. So this is long-standing, untreated hypothyroidism giving rise to, that high TSH acting on the FSH receptors with the specificity spillover giving rise to something called as a pseudo precocious puberty, also called as, anybody would want to answer this question? What is this? Van Wyk-Grumbach syndrome. So this is called as Van Wyk or Van Wyk-Grumbach syndrome, where you get the ovarian cysts due to long-standing hypothyroidism. What is the treatment? These ovaries are often prone to get torsion and gangrenous, so you are supposed to pick them up before they go into torsion. If you pick them up before they go into torsion, you simply treat with a plain simple 1 rupee tablet, that is levothyroxine, and this actually just goes away. It, the ovaries come back to normal shape within a matter of couple of months, and no surgery, no CEA, no CA19, no tumor markers, nothing is required. Just plain simple thyroid replacement. So if you happen to see any ovarian mass, please send a thyroid profile. It's worth sending because you might be saving one girl from getting under the surgeon's knife. Now this is 4-year-old male coming to you with acne, increased phallic length, pubic hair that are present with testicles of 2 to 3 ml. We have been told in our adolescence chapter that the testicular volume of 4 ml or more is the first sign of puberty. Now, here is a 4-year-old male child with acne. Look on his forehead. They are florid acne in a 4-year-old male with pubic hair. Phallic length is like mid-pubertal, but very, very small testicles. So testes are between 2 ml and 3 ml. The colorful beads that you can see are actually the orchidometer beads. Orchidometer is a tool that you can use in your OPDs to measure the testicular volume. It's a very, very handy tool. You don't have to send these children to ultrasound to measure the testicular volume. So these testes are just 2 ml, 3 ml. Look at the phallic length. It's pubertal. So what is going wrong here? Is this child in puberty? Yes, because you get phallic enlargement and pubic hair with acne. Is this true puberty? No, because the testicles are small in size. So this child is making testosterone from somewhere, but definitely not from the testes. So from where are the androgens coming? So there is another organ in human body, that is adrenals. Correct. So the adrenals are actually pouring out the adrenal androgen. So this is clear-cut case of congenital adrenal hyperplasia. Now, can I simply make a diagnosis of CAH just based on these two images? No, because this could be adrenal carcinoma also, or it could be any adrenal pathology, not necessarily CAH. So here I need to dig into some more history. So in this, it was a delivery by consanguineous union, and I have some additional history that dark complexion has been present and it has been worsening. So we sent out a sample for 17 hydroxyprogesterone and we could get the diagnosis. Now what is this? These are the spotters. These are the girls that are going to come to you for their cough and cold, and you will be examining them and you will be missing these subtle features of puberty. Please pay attention to that fine underarm hair. These are the axillary hair type 2, the stage 2. So axillary hair 2, and the breast buds, very, very subtle change in the nipple contour, slight color change, and if you palpate these nipples, they will be having tenderness. So the moment you touch them, the girl will wince. So any such signs in a 8-year-old or a 7-year-old or a 6-year-old, amounts to precocious puberty. So all clinicians that are attending, please remember that pick them up at this stage. Sadly, the girls come to the endocrinologist after they have started with their menses. कि अभी period start हो गया, menses start हो गया, अब इसको क्या करें? So that is not the time where you will be picking them up. This is the B2 and P2 or the A2 stage where you are supposed to pick them up and evaluate or refer for the precocious puberty. Now, this is one spotter where there is an 8-year-old male child coming to you with 2 episodes of seizures in the morning time, required IV fluid, and IV fluids are required for all trivial reasons. Little bit of cough, cold, fever, the child becomes drowsy, goes to the emergency room, and the moment the emergency staff gives a DNS injection, some IV fluid with dextrose and electrolytes, the child comes back to life and behaves like nothing has happened. But there is no weight gain for last 1 year, and there is pigmentation over the gums and the knuckles. Yes, you are absolutely correct. By now, you have already made out that this is Addison's disease, and this pigmentation is happening due to high amounts of ACTH. So this is the adrenal failure giving rise to Addisonian crisis, for which the child requires admission and IV fluids. But what is the diagnosis? Is it just plain simple Addison's? Addison's means failure of the adrenals, but why? Why is it happening at 8 years in a male child? So let's dig into the history. Addison's, of course, the clinical clues are the pigmentation in this particular case coupled with hypoglycemic episodes and lack of weight gain. Pigmentation we have already seen, but why is it happening in this 8-year-old? Any clue? What is the common cause of Addison's disease in a male child with at the age of 8 years? So here I will ask for the history of similar illness on the maternal side. If there is a maternal uncle that has had similar episodes like mama with pigmentation and some early childhood death or adolescent death happening in the maternal uncles, then I'm almost sure that I'm dealing with X-linked adrenoleukodystrophy. Look at the eyes. If you see absent tears, if the child is having absent tears with Addisonian features like this, then you can make a diagnosis of Algrove syndrome, that is AAA syndrome. Okay, these are the children that will come to you again in the same age group. I remember in my training where I was looking after one girl who was labeled as Addison's, probably idiopathic or autoimmune. And as I was taking her history, she was eating bhakri, and she was not able to just swallow. And I just intuitively asked that, why are you drinking so much of water while eating bhakri? So she told me, sir, I have difficulty while I eat solids. So immediately that diagnosis came to my mind. This is achalasia cardia in a girl with Addison's disease. So this is Algrove's syndrome. So maternal history, maternal uncles affected in a male, think of X-linked adrenoleukodystrophy, and associated alacrimia, achalasia, think of Algrove syndrome. Now this is an obese boy or girl coming to you, obesity with polydactyly and night blindness. So this is the fundus picture where you can see retinitis pigmentosa with polydactyly on the post-axial side. What is post-axial side? On the little toe side, not on the big toe. अंगठ्याच्या बाजूला नाही, करंगळीच्या बाजूला. Okay, so you see something like a Hrithik Roshan where the thumb is duplicated. That is not significant. Post-axial polydactyly is generally significant in these cases of obesity. This girl also has poor vision. What is the diagnosis here? Satish sir, I'm not able to read through the correct. So what if I remove the polydactyly and again put the same case? Again, same case, infantile onset obesity with photophobia but retained IQ and no polydactyly. Then it becomes Alstrom syndrome.
Alstrom.
So these two syndromes are very, very important. Alstrom and Bardet-Biedl. So LMBB syndrome will have post-axial polydactyly with impaired cognition, impaired IQ. So they are generally having impaired, what is the correct term? It's intellectual impairment. But in Alstrom syndrome, the intellect is absolutely normal. So these are the two similar syndromes that one should be aware of. Look at the eyes of this 3-year-old girl, and she is looking at you very, very angrily because you have been pricking her every now and then for fever of unknown origin, and she's very angry. मुझे कितने बार चुभा रहे हो आप? So she has been admitted for 2 weeks with fever of unknown origin, and she has, daily 1 or 2 fever spikes reaching 100, 101, excessive sweating, weight loss of couple of kilos. The heart rate is 140 even when she is afebrile. 2D echo has been done because she has persistent tachycardia, and somebody had listened to a cardiologist mentioning that there is something called as subacute bacterial endocarditis or bacterial endocarditis that comes with PUO, and the echo has been documented normal. Look at the eyes and tell me the diagnosis.
Yeah, most of them are diagnosed hyperthyroidism.
Correct, but would you be diagnosing this girl at 3 years? 3 years? Is it common? No, it is common in pubertal age group, but this is the extreme form of Graves. This is in fact Graves orbitopathy. That is absolutely correct. But then this girl actually was referred to me for failure to thrive, and she has had multiple episodes of IPDs, admissions for fever. So this is a real case, 3-year-old girl with Graves orbitopathy.
So this is because of some tumors?
No, this is plain simple autoimmune Graves disease, but happening at 3 years, which is a little bit unusual. Yeah. This is typical Graves orbitopathy that comes to you during adolescent age group. You must be remembering all those ophthalmological signs from your MBBS times, where you have the lead lag, the retracted lead, the chemosis, etc., and the staring look. This particular girl is not Graves. The one that I showed in the first slide is actually Graves. This girl has come to me with orbitopathy, but she actually had hypothyroid, in fact Hashimoto's. So commonly we see eye signs in Graves, but rarely we have seen eye signs in Hashimoto's also. So it's an association with thyroid disorders. This Potter, I think everybody will be able to give me the diagnosis. 8-year-old male, normal growth and development, 3rd degree consanguinity. There are skin lesions over joints, tendons, buttocks over last 2 years. What is the diagnosis? Look at the distribution of that pearly white, that skin lesion. It is present on the skin flexures and also joints and the tendons. So yes, these are the xanthelasmas of hypercholesterolemia. What is hypercholesterolemia and hypertriglyceridemia? These are two different entities with two different enzymes being involved. This is the xanthomas of your hypercholesterolemia. So look at the cholesterol value here. This is above 705, above the limits of detectability. So these are the fatty deposits due to high amounts of cholesterol. This particular case, I have around 6 or 7 of these with homozygous LDL receptor mutation, where they have very, very high amounts of cholesterol and LDL in the circulation, which gets deposited. Something similar that you will see in calcinosis cutis. What is calcinosis cutis? It happens generally on the knee joints, the elbow joints, but there the deposits are chalky white in color and very hard. The deposits in your hyperlipidemia or dyslipidemias are very, very fleshy and very soft and yellowish in color. The calcinosis cutis are white in color, and on X-ray, you will see calcinosis cutis as the calcified skin on the X-ray. So these are called as xanthomas, common, not very rare. You have to just look for those in your OPD. They are not rare. 10-month-old male child, 67 centimeters and 10 kilograms, excessive facial hair, plethoric face, moon fishes, hypotonia, and motor delay. What is the diagnosis here? Yes, this is moon fishes due to excess steroid, either iatrogenic or endogenous. Most commonly at 10 months, they will be taking some medicines on their own from outside, or there will be some skin creams being applied. So this particular child was taking Dexona drops from outside. This is the exogenous Cushing's syndrome. So Cushing syndrome, short and obese, is the clue. Thinning of skin, excessive facial hair, thick violet striae. Please remember, the obesity will also have striae. Simple obesity, but they are thin violet striae. These are the thick. If the striae are more than 1 centimeter, then you can almost be certain that this is Cushing's syndrome. Often associated with skin infections. Please dig into the history of skin creams. Often the diaper rash creams have steroids in it, mometasone, clobetasone, very, very high potency steroids. When applied over a period of time, can give rise to Cushing's. What is this? This is a 4-year-old male comes to ENT surgeon for the complaints of snoring at night. Ratri ghorto, kharrate leta hai. ENT has evaluated and there is a mass at the base of the tongue which is planned for surgery, and you have been called to give fitness. Being pediatrician, you are asked for a fitness so that this child can be posted tomorrow for surgery. Will you give fitness to this child? What is this?
No.
So this particular one, yes, this is ectopic thyroid gland at the base of the tongue. This is the only remaining gland. If you remove this, the child is going to go into frank hypothyroidism. So how to confirm this, the diagnosis? The diagnosis could be confirmed by 2 ways. One is, you palpate the rings of trachea. Normally, if you palpate 100 boys or girls for the thyroid, you will know that the trachea is covered with the isthmus, and suddenly for a couple of rings you are not able to palpate. So that feel of that thyroid isthmus is absent, and here we call this as the bare trachea on palpation. Bare meaning no thyroid there. You could also do an ultrasound where the sonologist will say that there is no gland in the neck. So this is the gland that is hidden at the base of the neck, base of the tongue. The second, more sophisticated diagnostic tool is to get a thyroid scan where you can see no thyroid gland in the neck, but there is a huge circular mass at the base of the tongue, which is the lingual thyroid. No surgery required, just treat this child with levothyroxine because the TSH has marginally gone up. TSH is 14, T4 is low normal. You give levothyroxine, the TSH goes down, the gland actually shrinks, and snoring improves. This is 4-year-old female, short since first birthday, doll-like fishes, normal development, has had history of hypoglycemia during neonatal age group. The weight is 13 kilos, height is 79 centimeters, very, very short. But weight is preserved. So this is spotter, clearly a case of growth hormone deficiency where the doll-like fishy is very, very high-pitched, shrill voice in a short child actually gives you the diagnosis of GHD. In boys, you will be particularly looking for the micropenis and mid-facial hypoplasia in both the genders, micropenis in boys. So short and obese, please remember, proportionate short and obese is endocrine. Disproportionate short and obese could be skeletal dysplasia. Always rule out thyroid in every short and obese child and then refer to pediatric endocrinologist for a GH stimulation testing. What is this sign? Now we have seen growth hormone deficiency, which is extremely short. This is a boy that is very, very tall and thin with spider fingers, arachnodactyly. what sign am I, what sign is being displayed on your screen? This is actually my hand. The one that is holding is my hand, and this is the patient's hand with the one phalanx of the thumb is actually popping out of the fist. So what sign is this? And which syndrome am I showing in this slide? सतीश सर आलाय का कोणाला?
या ना आलंय सिंड्रोम सगळे ओळखलंय मार्फन.
Okay.
साइन I think one percentage is Steinberg sign.
Okay. So this is indeed Marfan's, where you have arachnodactyly and the part of the thumb is actually protruding. Very easy to demonstrate. तुम्ही सगळे करून बघा, तुमचा अंगठा बाहेर येणार नाही. If you do this, your thumb will never pop out of your fist. So this is one clinical clue towards Marfan syndrome and also homocystinemia. This is 6-year-old female. Look at her.
Sign कुठलं आहे? Sign, what is the name
Sign
of the
आपण
sign?
सांगू. थोडं सस्पेन्स राहू दे, आपण येणार आहे तिकडे परत.
Okay.
Yeah, so this is 13-year-old with enamel hypoplasia. Look at the wrists. This is wrist widening and gradually worsening genu valgum. तिचे गुडघे वाकडे वाकडे व्हायला लागलेत, and the distance between the malleoli has been ever increasing. She also has nocturnal enuresis, and only after a thorough history you could dig out that she drinks 3 liters of water and passes 2.5 liters of urine. So this is in fact polyuria in a case with rickets and short stature. So I'm sure you must have guessed the diagnosis already. This is renal tubular acidosis. When we present this case like this, everybody is jumping with the diagnosis. But when these cases are seen by the pediatricians, nobody thinks of RTA. They are referred to orthopedic surgeons. Why? Why, as pediatricians, we fail to recognize that genu varus, genu valgum are treatable conditions medically, and almost 95% of them will not need any surgical treatment. What you need is just correct diagnosis and correct treatment, and you can prevent surgeries in most of the rickets and genu valgum or genu varus. So this is pediatrician suspected nutritional rickets, gave 6 lakh units of injection of vitamin D. This is the X-ray. No healing response in 2 months. Blood work showed alk-phos of 593, calcium normal, phosphorus is low with a normal PTH, pH of 7.13. So here we have acidosis, bicarbonate of 11.6, base excess of -18, vitamin D of more than 100. So this is vitamin D toxicity, iatrogenic. Because we failed to get the diagnosis, we kept on giving vitamin D, tons and tons of it. So this is renal tubular acidosis with vitamin D toxicity. What is this ultrasound showing you on your screen? Anyone?
Calcinosis.
So this is nephrocalcinosis. Absolutely. So the medullary calcification you can see here, and this is the clinical photograph. So what is the diagnosis?
Fanconi. Fanconi.
No, this is not Fanconi. Fanconi is the proximal RTA. This is associated with hypercalciuria.
So type 4.
So this is distal RTA. Distal RTA giving rise to nephrocalcinosis. Yes. Moving ahead, what kind of rickets are we looking at? So this is short stature with florid rickets, alopecia, and delayed dentition. Extremely painful condition. These children can barely walk. If they are not treated well, they will never walk. Only if you give them the correct therapy, they will probably walk. They often come to you with hypocalcemic seizures. Any diagnosis? Yes, this is vitamin D dependent rickets type 2, VDDR type 2, a very difficult condition to treat. you treat them with mega doses of vitamin D daily and also large doses of calcitriol. किती मिनिट आहेत सर आपल्याकडे सतीश सर? Another 10 minutes?
No, half an hour,
Half an hour.
20 minutes, 25 minutes.
Perfect, perfect. So this is 8-day-old male child admitted with lethargy, poor feeding, unusually dark skin, no ambiguous genitalia. The child comes to you with cold peripheries and feeble pulses. Sugar is 45 mg%, electrolytes 129 of sodium and 6.8 of potassium. Look at the color of the baby, the pinna. It is actually giving you the diagnosis. Could this be CAH? But then there is no ambiguous genitalia. Can this be CAH? Look at the gender, male.
Yes.
Yes, males could come to you without ambiguous genitalia directly in
Shock.
a state of Addisonian crisis or shock. So this is indeed the same thing happening. So this is a case of male neonate coming to you with shock. So think about CAH, the salt wasting variety, when you have a male neonate with shock, and non-salt wasting CAH in a male comes to you with precocious puberty. The salt wasting CAH male comes to you with neonatal salt wasting crisis. What is this? This is 5-month-old male child, delayed milestones, umbilical hernia, coarse cry, constipation, and birth was attended by a pediatrician. What is diagnosis here?
Congenital hypothyroidism.
No, that is very evident. I am asking what is the diagnosis here. This is medical negligence. The diagnosis is medical negligence. And the pediatrician is going to receive the summons by court saying that you had attended the labor call. Why did you not write on paper that TSH screening is required? And the parents are now wanting a compensation. So please beware of screening. TSH screening is mandatory. The ISPE and IAP joint, both the professional bodies now recommend TSH screening either at cord blood or after 72 hours of life. So please write on paper. It is the parents' wish whether they do it or not, but please be safe medico-legally, and it is actually medico-legally important. So ISPE recommends universal newborn screening for congenital hypothyroid, either cord blood or 48 to 72 hours. The cutoff that you must remember is 20. I think we can skip this. This is available on the ISPE website. You can go through this flowchart, very, very easy. 20 is the cutoff. Now, just give me 1 second. Yeah. So this is the spotter. The child has come to you with his grandmother, and the grandmother is anxious, coming to you with, oh doctor, the nephew does not have a penis. Penis kaha chala gaya? So apparent micropenis is commonly buried penis due to obesity. Now, how will you convince this grandmother that has come to you with this kind of picture?
You take a length, penile length.
Right. So stretch the penile length, but penis is correct. So this is how you just push the pubic pad of fat, and the penis will actually come out. And you check the phallic length from the pubic symphysis until the tip of the glans. Do not count the preputial skin in the stretched penile length. Just count until the tip of the glans. This is the buried penis, very, very common. And we are
For that
actually
2.5 centimeters is normal.
Yeah, correct. So that again depends on the age, but by and large, yes, up to first birthday, the cutoff would be, at birth, the cutoff would be 2.5 centimeters. At first birthday, it's around 3 centimeters, and by 10th birthday, the cutoff is 4 centimeters. Beyond that, you have to refer to the local charts. This is 15-year-old boy, came to you with obesity, with delayed puberty, has left-sided hip pain, has come to you with waddling gait, and this is the X-ray. So what is going wrong here? Boy, obesity, delayed puberty should ring bells in everybody's minds. Am I dealing with some condition that is preventable? Yes, this is slipped capital femoral epiphysis, very common in obese individuals, very common in obese boys with delayed puberty. So think of Klinefelter syndrome also, because Klinefelters can also come like this with delayed puberty and obesity. But any obese boy or girl is likely to have this, and this is actually preventable. If you take care of the obesity right on time, you can actually prevent this SCFE. Okay. Poorly controlled seizure in a pediatric age group patient with short fourth metacarpal and poor scholastic performance. What is the diagnosis here? First, what is the sign that we are looking at on our screens? You can see that the fourth and the fifth metacarpals are very short, and it is giving rise to the shortening of the overall digits. If you make the child fold the, make a fist, you can see the dimple on the fourth or the fifth metacarpal head, which is called as the Archibald sign. It's called Archibald sign, which is commonly associated with hypoparathyroidism and Turner syndrome. So in this case, the child was having poorly controlled seizures. He was on multiple anti-epileptics, but still the seizures were going on and on and on. A simple clinical examination would have alerted the pediatrician about the diagnosis of hypoparathyroidism, giving rise to refractory hypocalcemia, giving rise to poorly controlled seizures. So here the treatment of seizures is not anti-epileptics. The treatment of seizures is activated vitamin D along with calcium, that is calcitriol with calcium will take care of these seizures. What is this?
Tetany.
This is the carpal spasm. Often we say carpopedal spasm. So pedal is the legs, carpal is the hands. So this is very painful. The girl actually came to me crying, and the grandfather was also very much in a panic situation. Somebody told that this is a seizure, and some haath kadak ho gaye, haath tede ho gaye. Somebody would be loading her with phenytoin, or some Gardinal is being given. So this is hypocalcemia giving rise to tetany in a case of hypoparathyroidism. Now, if the same girl is an adolescent girl coming to you with tetany, this may not be hypoparathyroid. This could be plain simple vitamin D deficiency. Because adolescent girls don't go out in the sunlight, they are highly deficient in vitamin D. The first working diagnosis for any tetany will be hypocalcemia due to vitamin D deficiency. So any such patient comes to you, you will be putting an IV cannula. Please do couple of things. As you put IV cannula, collect blood for calcium, total and ionic, not just total but also ionic, vitamin D, and PTH. And that PTH vial, you just please put in ice, because in summer times, if the PTH is lying around at room temperature, the PTH will vanish in no time. So if you're really concerned about the PTH, collect the sample, put it in ice, call up the lab and tell them that I need the calcium values stat so that I can decide whether I need to send the PTH or not. Okay. Now, 3 conditions with nail affection. This is first condition. Look at the nails. How are the nails? They are pigmented nails. Pigmented nails, pigmented skin, pigmented oral mucosa. This is Addison's disease. Second nail condition. Now I'll wait. All of you can type. This is a girl that has come to you on her 10th birthday, extremely short, 10-year-old, 120 centimeters, and these are the nails. What is the diagnosis here? This is far common than growth hormone deficiency or hypothyroidism. This is iron deficiency anemia. So this is the spooning of the nails, platinoikia or the spooning, not just flattening, but the spooning. Koilonychia. Correct. So koilonychia is the spooning of the nails, very, very common in nutritionally deprived young girls, not just adolescent, but pediatric age group also, very, very common. So here you would
The height is very low.
extremely low. After looking this girl, I was almost sure that she will turn out to be some endocrine cause. But after looking at the nails, I was sure that this is plain simple nutritional. So we just treated her with iron and deworming, and she just started to grow, and now she is having normal height.
Yeah,
This is
some
third.
pediatricians type the celiac disease also. This can be a celiac disease.
Absolutely correct. So as a part of your malabsorption, why is she not absorbing iron? So as a part of the workup, one may also think of sending a sample for TTG IgA. If your patient has any other clues like abdominal distension or steatorrhea, please go ahead and send TTG at the first instance. But if there is no other suggestive features such as abdominal distension, no greasy stools, no other vitamin D, other vitamin deficiencies such as white spots, etc., then you may give iron, wait for a couple of months. If there is no improvement by oral iron, then as a part of second tier examination, you may think of celiac disease. Of course, asterisk mark, if the patient is hailing from northern parts of India, then you will be sending the TTG right at the diagnosis of iron deficiency. Now comes the third nail condition. The child has come to you with abdominal complaints and short stature. The child has to go to the washroom at least 2 to 3 times in a day, often plays sick. He has abdominal complaints all the time and this kind of nails. So this is actually celiac disease. The clubbing is grade 2, not very subtle, but not very marked also. Somebody would argue 2 versus 3, but this is, one has to carefully look at the nails, and clubbing is often missed in short stature. It is actually giving us a lot of clue. This child has come to me for growth hormone testing. Somebody had told him that growth hormone कम होगा, growth hormone check करो, injection ले लो, लंबाई बढ़ जाएगी. And the subtle clue in the nails gave us the diagnosis of celiac disease in this particular patient. What is this sign? This is the prayer sign, where the child is attempting a prayer, but the hands are not touching each other, the digits are not touching each other. What is this? Anybody?
Somebody has put the JI also.
JIA is of course possible, but let me give some background for this child. Actually, this is not a child. This is a 21-year-old girl, has been having type 1 diabetes for last 10 years. She is irregular with her follow-ups. She does not check her sugars regularly. She does not document her sugars regularly, and she often skips her insulin. As a result, her HbA1cs have been very, very, very high over last 10 years. And as a part of her poor glycemic control, she has had something called as diabetic chiroarthropathy, where the advanced glycated products have deposited in her joints, and as a result, she cannot touch the fingers. So this is one namaste that you never want to see as a result of poor glycemic control. So this is the prayer sign in type 1 diabetes with poor control. So that was a small attempt from my side. आणि सतीश सरांनी ते साईनचं नाव विचारलं होतं, मला अजूनही काही आठवत नाही. इफ समबडी रिमेंबर्स what is the sign in Marfan syndrome where the thumb is popping out? I can now say that I have started to become senile. So I really don't remember the name of the sign.
Steenberg was the written answer.
Steenberg sign, probably. Yeah, probably. So these images were all my patients. I have a huge collection, but I could fit in just whatever I could gather, and I could deliver in 40-45 minutes. I still have a huge collection. Someday we can have a fresh set of
Yes, sir.
PPT.
Yeah,
Thank you.
definitely. I think, Tushar, what we can just have another 2 points important on the screening of thyroidism, because we have got 5 minutes more. So people has to get a clear message about that, because most of the things what you have mentioned about 6-month-old child who has been undiagnosed hypothyroidism. So that things I think we should not have in our practice. So we can have just 2 minutes of that guidelines from you.
Sir, can I ask you one thing? Now,
Yes, sir, please.
is it medico-legally mandatory to get the TSS done within 72 hours?
Yes, because we have a guideline in place.
Okay.
So we have the Indian Society for Pediatric and Adolescent Endocrinology, ISPAE guideline, which is endorsed by our national IAP.
Okay.
Yeah, so it is now on in black and white. We have to follow.
Thank you, sir.
So
Yes.
TSS cutoff of
Right, sir.
hard blood 72 and 7 days.
Correct. So the first sample that we send is for TSH only, and that cutoff is 20. So be it cord blood or 72 hours, the cutoff is 20. Okay. Now this sample, if it turns out to be 22, 25, or 27, or 30, or 35, or 40, whatever may be the value above 20, you are not going to start this child immediately on thyroid, because this is just a screen positive. It is a screen positive that you are going to ring up and call back in your OPD and send a confirmatory sample. The confirmatory sample has to be T4 and TSH. The T4, the cutoff is 10, and the TSH cutoff again remains 20 until 15th day of life. Beyond day 15, the cutoff becomes 10. So on confirmatory sample, if the total T4 is less than 10 and the TSH is above 20, then you can start this child with levothyroxine replacement and give a call to your pediatric endocrine colleague. If you have one available in your town, just give a call. If you don't have a pediatric endocrine colleague in your place, just start thyroid replacement. That starting of thyroid is very, very important. Later on, we can figure out whether the child is temporary hypothyroid or permanent hypothyroid. We can figure out later. But diagnosing and starting them on levothyroxine is important. The figures to remember is 20 and 10. 20 as the screening TSH cutoff, and for T4 it is a T4 of 10 or below with a persistent TSH 20 and above until day 15 of life, and any TSH above 10 beyond 3rd week of life. So I think 20, 10, 10 is the figure to be remembered. And maybe President Sir is there, if Maharashtra IIP can take an initiative and declare 20th of April as maybe congenital hypothyroid day. Just a preposition from my side, because 20 is the cutoff for TSH and April is the day 4 of life. So you could take an initiative and declare it as thyroid screening
Everybody
day.
gets sensitized.
Yes, sir. Definitely we'll try to do that.
4 means what? 4, 4?
April, Amol.
April and day 4 of life.
20th April.
And
Day 4.
So day 4 to more than 20 is abnormal.
Yeah.
To tell all of you, Tushar visited my town. It's at Satana Taluka place, and in before COVID time, just I think 7 days before the lockdown started, he was in Satana for one CME, and he has told all the practitioners that we should do the thyroid profile testing of newborns immediately after birth or after 72 hours of life. So from that time, almost I have done more than 700 this thing, and I could find one patient, one baby with hypothyroidism. So it was good, this thing, good information, and good persistence of Tushar, because of which we can catch that one child.
Yeah. So you're maintaining the ratio of what is written in the book, 700 to 1 ratio.
Right. It's around 1000
I
to
think
1. Yeah.
Medical legally it is very much important.
Very
yes. So over to Vikas now.
Srinivasan sir.
Yeah.
Srinivasan sir.
I think
Your-
Bhavesh wants to say
Your
something.
comments. Pallavi ma'am, please unmute, sir.
Done,
Pallavi
sir.
ma'am,
Done.
please
Done.
unmute
Yeah,
everyone.
yeah.
Done,
Now
done.
they have this thing
Done.
allowed me to unmute. So it is wonderful. Of course, wonderful this thing revision of endocrinology, and all of them are excellent pictures. Not too difficult for postgraduates to answer. Excellent. Yeah. And
Sir, I
yeah,
think we can have one dedicated session for PGs also, where we can put some googlies, some difficult ones.
Yes,
This
nice
was for
idea.
practice.
a very good correction, and I'm sure you will be again coming to the platform back to enrich. Yeah, it's very important, especially with TASCI, etc. So this type of training is very important. I thank the Maharashtra for taking this. Of course, last year we enjoyed the private practitioners in various this thing. They were conducting regularly case discussions and how they come to a diagnosis, etc. And this is
Yeah,
as
my epic case
interesting as that
challenge.
one.
Sir,
Yeah.
for
Epic
that
case
we have
challenge.
another
Yeah.
series that is called as Casebook Live.
Facebook Live.
It's as interesting as that. Yeah, very important, especially for undergraduates and postgraduates. Yeah.
I will send
Of
that
course,
link
you
to
mentioned
you.
about the hyperthyroidism, Darling-Pool signs, Stelwag sign, all these things people would have forgotten because they don't, anyhow. That child with hyperthyroidism was this thing, and hypothyroidism, Addison's disease. You have covered almost all the gambit, and including Albright syndrome, etc. Very good. Thank you so much. I learned a lot.
Thank you, sir. My pleasure. My
Thank
sincere thanks to President Sir, Dr.
No, sir,
Ramgopal
it's our pleasure. Almost 400, you can say, 385 delegates.
Okay, should I put a hands? Sir?
Yeah.
Yes, yes.
Yeah.
Yes, sir. Yes.
Anybody
So,
wants to give any comment? I think he's welcome.
Bhavesh sir, Bhavesh sir.
So if again Dr. Ramgopal as a president agrees, then 20th April and for next 10 years, you should keep bombarding with this information so that we remember 20 for TSS and 10 for T4 so that people will remember this.
Definitely the flyer and message will go on 20th. Amol wo Abhishek Vishal ko laga do काम पे.
Yes, Vikas sir, please.
yeah, so we touched 384 delegates. It was a remarkable attendance today. And I think there are many multiple aspects. First is concept is so nice. Second is the speaker like Dr. Tushar. Everybody was eager to listen to him, and we were very eager that in what way he will present endocrinology through a pictorial format. It was a very fantastic presentation. Thank you so much, Dr. Tushar, and Dr. Satish Hane for very ably moderating the session. And most of all, our own Dr. Bhavesh Mithia sir, who is actually steering this project very nicely, and he is pushing all of us to sustain this momentum. And we are getting appreciation from all over Maharashtra just because the kind of enthusiasm being put forward by our dear President, Dr. Ramgopal sir, and very enthusiastic Secretary, Dr. Amal Pawar sir. I am so much fortunate to see so many stalwarts like Dr. Srinivasan sir, Dr. Nitin Jain sir, Nitish Shah sir, Anjali Gokan madam. So many seniors joined today, and so many PG students were giving their very valuable inputs during the his presentation. So it was a completely involving session. I was feeling like just diving in the ocean of knowledge. So it was a very nice presentation. I really enjoyed myself very much. If I am forgotten any name, I'm really sorry for that. At the end, again, Eid Mubarak to everyone for this auspicious occasion. And I will request Ramgopal sir to say one word at the end.
Please join us on 18th. That will be learning from the legends. And this time we will be having Dr. Uma Ali madam as a speaker. So requesting everyone to join on 18th.
Yeah.
Very nice.
And 17th also, sir. 17th also Wednesday.
First on 17th.
Sorry, 17th will be the Wednesday wisdom.
We have a symposium on this thing, pediatric neurology. pediatric
Yeah.
neurology.
So I
Dr.
think
Anand,
So
Dr.
now,
Anand Diwan and Dr. Chandana Bhagwat, they are the these experts, and there are 5 young
Experts
speakers.
for this session.
Yes, there are 5 young speakers from all over Maharashtra.
Yeah.
I think everybody is finishing OPD before 9 o'clock. That's why it is again a very important reason for higher attendance.
One thing is, we already by 9 o'clock, we always have more than 200 pediatricians joined. So that speaks the success of the program.
Very, yes, very true, sir. Very true.
And
thank you so much.
Manjusha, madam, I think anyway, your program is the most highest delegates. Last time we had 450 delegates.
Yes.
No, but
Very
they
true.
should mark, sir. They will mark only 18 then. They should mark 17 also.
No, I
Oh,
will definitely.
no. This is
Yeah.
why he forgot the 17th because why?
Because actually we are having